Good morning, everyone.
Morning.
All right, last day of APHA. So much like me, this is probably what the longest number of consecutive hours you've gone without having sweatpants on. So we're all anxious to get out of our suits and put them back and not have to have our tops match our bottoms. So this is great. What we're going to do today is a little unrehearsed session with some great panelists looking at what's happening in public health and where we're going. And so think of it, for those of you who are old enough to remember the McLaughlin Group. So think McLaughlin Group meets Ask Me Anything. And I want y'all, this is an interactive session. So I'm going to be asking you some answers. I want to hear from folks out there. We're going to ask for your questions. So this isn't going to be just a talking head session. Okay, so today I am super fortunate to be joined by this wonderful panel. I am Brian Castrucci. I'm the president and CEO of the Beaumont Foundation. If you don't know the Beaumont Foundation, follow us on Twitter, visit our website. And the illustrious panel, I will start on my far left with Perry Halkitis. Now, Perry's the dean of Rutgers, and that's the day job.
Yeah.
But I mean, disruptive, cool. Like your photos on Twitter, I can't be that cool. As my wife and my children tell me all the time, I cannot be that cool. So having Perry here is someone who's thinking about schools. You know, what is the curriculum? How do we train our students? So that's why Perry's here. Marissa Levine is the former health commissioner of the state of Virginia. She is also a leadership expert working at the University of South Florida and is our partner in the emerging leaders in public health that she is redoing for Kresge and de Beaumont and Johnson, and just an amazing thought leader in the space. And we'll talk a lot about clinicians in public health practice, but you know, Marissa's different. Marissa came up through health departments, through public health. She knows this work. Zamir Brown has the exceptional pleasure of working at, I think, one of the most courageous foundations in the United States. You work for the Beaumont Foundation.
I think so.
Okay, that's good. So Zamir is a senior program associate with us at de Beaumont. He's been with us in de Beaumont years for about 5 years, which in real time is
10 months.
10 months, okay. So Zamir is here kind of representing, you know, youth in public health, that early career professional. So it's not just, again, kind of the old guard talking, but, you know, mixing in that perspective. So again, questions for him that you know, how did you get to de Beaumont? How did you figure out a career, right? Because the hardest thing for us in public health is it's wonderful in that you can do almost anything after you get an MPH. You can go almost anywhere. But it's hard because you can do almost anything after you get an MPH and go almost anywhere. And that's really hard. And then the illustrious Daniel Dawes from the Satcher Health Leadership Institute, author of Political Determinants. I'd like to thank Perry and Daniel. I hope you all get the signed books. I have known Daniel for many years. Political Determinants of Health is seminal. And read that book, read Talking Health and Public Health Under Siege, read those first, but then read Daniel's book. Daniel, thank you for being here. So, hey, let's just get started. Issue 1. We had an election last night. Not quite sure that anything much changed. We definitely, I think, rejected extremism. But what does this mean? What is this election? Because we can't ignore that an election happened last night. We're the 8:30 session the next day. So, Daniel Dawes, what does the election mean for public health?
Oh, I knew you were going to call on me first. So, you know, as I was staying awake, I barely got any sleep last night, and I do it to myself every election, you know, anxious about the results. And I was thinking about, when I woke up this morning, what does it mean, right, for this health equity movement? I believe that we are in the fourth period of a great awakening for health equity in this country. And every time we've had an awakening in this country, we've had periods of retrenchment and what they call regressive devolution. We've had backlash. We experienced that, of course, prior to this administration. And so I feel like we are going against what history has shown, right? Where that period of retrenchment takes years for us to mobilize again and get back. This election caused me to think about the opportunities. While elections aren't finalized right now, But I do think, when folks were talking about this red wave, I thought, oh my goodness, here we go again. What is this going to mean for this health equity movement? And what is it going to mean at local and state offices as well? And I have hope. I have even more hope after seeing the results this morning, last night, that we can make a difference. There is hope. And I know I've spoken with folks from different parts of the country, especially those in states that have really been battling prevailing winds, opposing this health equity agenda. I see some glimmer of hope moving forward. So that's what that means for me.
Perry, what do you think?
I did not watch the election returns last night because I could not control what was happening. I was watching instead some horrible Hallmark Christmas movie, which was okay. It was
Like
something about
Follow
gingerbread
Lifetime?
houses. I don't know. It was everybody was in love in the end. It was all fine. To me, it means several things. One, that people matter and people have to be at the center of everything. And I think one of the most important things for me as a dean of a school of public health is reminding our students and teaching our students that we are in public health. That means that we don't do just work behind computers. We do work in real life with real people who have real lives. That's number one. And I think the election spoke to last night the idea that people make their destiny, right? And people make their destiny when we create conditions for them that allow them to thrive. We have a long way to go in this country, right, in terms of allowing people to thrive. But certainly last night, without the red tsunami happening, as an indication of what we do to make people feel safe in their voting, to hear their voices heard. And in terms of public health, I mean, woman's right to choose. Like, that was clearly a mandate from the American people last night.
So often, we did, one of the best things I ever did in my career is I got to work with Frank Luntz. And we worked on messaging around the vaccine to Republican audiences. The folks doing the Twitter, tag Frank and thank him for what he did to help us connect with Republicans who needed to get the vaccine but weren't quite sure, getting different messages. One of the most interesting focus groups that we had, I had a gentleman who was on the focus group and he said, I'm not doing this from my house. This was a Republican focus group, vaccinated Republicans. He said, I'm not doing this from my house because if my wife knew, she would leave me. So he was trying to sneak around to get vaccinated. I miss the good old days where you snuck around to cheat on your wife, not to get vaccinated.
Yeah.
So a lot of folks, we got backlash for that. Why are you working on Republic? You should be working in communities of color. You should be working in low-income populations. So how do you work across that political aisle with people who don't agree with you? And Marissa, you worked in an interesting state, and now you work in an even more interesting state. But how do you even do that? How do you justify that difference between idealism and practicalism?
Yeah, no, it's a great question, and I think back to my time as commissioner working in the health department. To me, the election means that we have to work with everyone. If we really believe in health equity, then all voices matter, even in the political arena. And I like to think I was able to work across the aisle, so to speak. And it came down to having relationships with different members of the legislative body. And some of those relationships went back to the time when I was a local health officer, and I got to know them at the local level. And I have to say, that's where the rubber hits the road. That's where the opportunity is for public health. Those of you working in local public health, those relationships will be critical to our ongoing ability to be effective in public health. And I was able to take that with me to the commissioner level. And I actually worked across the aisle and we created policy together because I knew it was policy they were interested in. And I listened to hear what it was about the policy that I could help with or that I needed to understand better. It's doable, and this is the workforce we need, people who have that ability to work really with everyone.
I think we have to remember that we're public health practitioners. Everybody in this room is a public health practitioner. You're heroes. Rochelle Walensky had a talk last night. We said they're all superheroes. Superheroes help everyone. Mm-hmm. And it's incumbent upon us to, I would often say to my own team, I don't care who we're helping. If there's a syphilis outbreak, I don't care if it's the most hated people ever. It is our job to address that outbreak and provide care, provide education, not buy into the doctrine. But Zamir, how do you help, especially I think early career professionals, balance that idealism versus practicality? And I think we've talked about this because I always say I'm at a time in my career where being practical is very important. And I think, we share a lot of colleagues at Beaumont who maybe still be leaning on the idealism side. So how do you think that through? How do you think that balance?
It's tough. It's very tough. A lot of times, the way that I ground myself, what I talk about with a lot of my colleagues is we're here to save people's lives. We're here to help people. So a lot of times we don't really have the luxury to just get so deeply entrenched in the politics. We have to look at who it is that we have to work with, build those relationships, and remember that it's actually about the people. It's very easy to get caught up with our ideals and not actually focus on why we started doing this, which is for people. And that's what I remind myself every day. And it's tough. I have to listen to a lot of nonsense sometimes, but there might be one thing that ends up being said where a relationship can be built, and then we can work together from there. And I think it's very important to remember what it is that we are trying to do. And that can be very difficult, sometimes. And we have to really make sure that we're staying centered on what it is that we're trying to accomplish.
Mm-hmm.
Thank you. I forgot to mention, we have a very, very talented artist with us in the back, Lauren, who goes by the Twitter name Dances with Markers. She is amazing, has done this for us before, and will be live drawing this whole session. And this is what we hope to take from this session. And I also want to welcome our viewers on YouTube. There's often the concern that not everyone can get to APHA. And so just from an inclusivity standpoint, Beaumont made sure that we had the live stream going so that people could participate live. And I have my phone out so that people can actually give me the questions from online. So online people, please feel free to send your questions in and interact with us today. Okay, so let's stay on this political tone for just another question. The pandemic demonstrated that public health is fiercely political, right? Not partisan, but it is political. You had a political job. You have a political job, right? You have a political job. You don't so much. Neither do I. So let's, because we have lobbying restrictions as private foundations, right? So it's harder for us to get into that fray. How do we, though, be more effective as a field in making the political case for public health? And Perry, I like you as a dean because I don't think of you as a dean. I think of you as an activist. Yeah, I mean, I think I think we share that in that I feel I'm a practitioner that someone let run a foundation, and God help them for making that choice. But I think you're a dean, you're an activist who someone let be a dean. Mm-hmm. And I think you infuse that into Rutgers. So I think it's a perfect question. Like, you've been through those political wars as an AIDS activist, and how do we even begin in this super polarized space to let people understand that health, every decision we make, if it's an economic decision, it's a health decision. Education decision, it's a health decision. Health is that foundation of our society, and when that foundation breaks, everything else is in jeopardy, and I'm worried about everything else right now.
Right. So I'll answer in two ways. So, and I'll answer in three ways. During the course of the pandemic, when the news would call and I would go on the news, I was always most happy to go on the news programs that were going to challenge my views, right? Because those are the programs where my messaging needed to get across more effectively. Number two, one of the things that I would say all the time, which leads me to the answer for your question, is why am I being vaccinated? And I always would talk about my brother, my younger brother, who's 3 years younger than me, who's living with progressive MS. And I would say, I do it for him. I love him. I don't want my baby brother to get sick and die. Which brings me to the point I'm trying to make. In health and in public health and in medicine, when we talked about it this morning while we were in the cab ride over, we depend too much on this notion that people make rational decisions all the time, that people are rational operators. So if we tell people to take their HIV meds every day, they're going to do it. If we tell people to take a vaccine, they're going to do it. To take their 10 days of antibiotic or their 5 days, they're going to. That's not what happens. And what we have to do more effectively, and this is the next book, I think, Brian, that I'm writing, well, it is the next book that I'm writing, is really how do we take public health paradigms and infuse them with the social conditions that people are living in, with the emotional lives that people have, and how do we build programs that actually we marry the rational with the emotional and the structural. Because the rational in and of itself does not work. And I was making a joke this morning, I swear I'll wrap it up after this. When I was starting my work in HIV research, like 25 years ago, I remember going to a CDC meeting with one of our first grants, and people were saying, well, you know, if people have high self-efficacy, they're going to use a condom every time, high self-efficacy. And I was like, 5 tequilas in and some hot guy walks in the room, self-efficacy goes out the window, right? And so this is the paradigm shift that needs to happen. And if we do that, people will see us as much more authentic than we are right now.
Thank you. So, Marissa, you're driving through Virginia, right? And you're going from blue to red and even deep blue to deep red.
Yeah.
How did you change your messaging along the way to keep folks engaged, depending whether they were in the reddest parts of Virginia, and then even now in Florida, which I think, you know, I believe last night the only statewide elected Democrat in Florida was voted out. Yeah. So there are everyone in Florida is a statewide election is a Republican. How do you do it?
So I think one of the key leadership principles is the good leader doesn't have to have all the answers, but the good leader has to have good questions and be willing to listen. And I think that's what I did in Virginia. My first role was to go and listen, ask good questions and listen to the answers. Because if you go with a preconceived message, I guarantee you it will probably be wrong. It probably will not be received or received well. Again, I'll go back to the fact, really, it's about creating those relationships. So I wouldn't just go and try to bring a message. I would go and start the relationship, and then I would go back. And I think it was most effective when I started to know people, they knew me. And this is really critical for public health. We have to become trusted entities. We have to be trusted people. We have to be trustworthy to be able to move forward. And you're right, the decisions, I just lived through a hurricane. Hurricane Ian hit my town directly, and I watched my own decision making in terms of evacuation. I realized everybody is making their own decision based on their history, their beliefs, their understanding, their connections, their abilities. And quite frankly, the people who died in Ian were those who were disconnected, maybe didn't have the means. And until we really believe that everybody matters and we create those connections, it almost doesn't matter what the message is, we are going to be ineffective. So I think public health, getting back to the comments that were made before, is really about assuring opportunity for everybody to be healthy and well, and that really means to be connected to community.
So I want to push on a couple things. I love public health deeply, but I'm not a public health apologist. And you said you have to say you don't have all the answers. Do you think that when, at times, federal leadership was speaking with far more certainty in COVID than they should have been, that set us up for some of the challenges that we then had with COVID? Did we almost till the soil to allow misinformation to grow because we spoke with certainty instead of saying we just don't know?
You know, I thought we learned that lesson during H1N1 and Ebola, that we have to be transparent and honest, and it's okay not to know. But when you tell people you don't know, you say, I'm coming back such and such a time, and we'll let you know as soon as we know, or here's when you hear from me again. We saw this in a lot of emergencies, and the more certain we are in the pandemic, for example, the more likely that we're going to breed distrust and misinformation. So I think we have to be comfortable with saying, I don't know, but maintain that connection and let people trust that we're working on it, and we will get back to them and give them some idea of when, and be open.
Thank you. One of the things I want to make sure people leave with is not just an enjoyable encounter today, but resources, right? When we think about communications, and that's a theme we're going to hit on throughout this morning session, a couple resources. I encourage you to visit the Public Health Communications Collaborative. This is a collaborative of the Kresge Foundation, Trust for America's Health, the Beaumont Foundation, CDC Foundation, Kaiser Permanente. And what we did is we kind of looked at the landscape of public health messaging. And the federal leaders would talk in the morning, well scripted, well messaged, And then in the afternoon, 3,000 health commissioners had to get in front of the media and then give an interpretation of that without any messaging, without any message testing. Sometimes you had some health departments doing beautiful infographics and advertisements about Halloween or holidays, but then some health departments don't even have a PIO. And so the Public Health Communications Collaborative is trying to bring together the public health army. And one of the ways we do that is we have consistent messaging. And so next time there is something that happens in the landscape, not just COVID, but now monkeypox or whatever the next challenge is, the Public Health Communications Collaborative is there to help you get some messaging that has been tested and worked by public health communications leaders. So key into that, we're getting ready to start the development of a communications boot camp for public health professionals. So lots coming out there. Use that as a resource. Also want to point you to phrases.org. Phrases, it's an acronym because we all took that course in public health school, how to name everything as an acronym. And so it's public health reaching across sectors. It's phrases.org. Phrases is the communications toolkit for the chief health strategist. It tells you how to talk to other people in other sectors. And it is also the foundation for one of the books you received this morning, Talking Health. So I just want to put the resources out there so that you leave this maybe with some, hopefully a laugh or two. Hopefully you think. Hopefully you learn a different perspective, but you go home with some resources that you can share with all your friends and family over Thanksgiving and your colleagues who weren't able to come to this session today or APHA. Daniel, political determinants of health. So we have to ask you, you worked for mostly Democrats in your political career, and luminary Democrats. You worked for Ted Kennedy, that's amazing. We're in Boston, so everything has, a Kennedy name on it. How do you work with Republicans?
Well, let me actually tell you how we did it. And we often found common ground. For instance, I'm a huge mental health champion, behavioral health equity champion, and worked on the Mental Health Parity Act. And I will tell you, we worked very closely with Pete Domenici, Republican of New Mexico, as well as Senator Enzi of Wyoming. And what I found during my time on the Senate Health Committee was that all of the issues that we were working on, both sides cared deeply about it. Many of them had loved ones who were affected by that particular issue and wanted to see change. What I realized during that experience was we had to be not only policy savvy, but have political acumen. You have to understand, the ideologies on both sides. And for me, coming out of law school, it was interesting. Folks think that you're just, political immediately, and that's not true. When I got there, I didn't know what Ted Kennedy's position was and what he had tried to carve out in parity before. I didn't know what the Republicans had been pushing from their standpoint, and I had to learn that. And I think, to my colleague's point, relationships matter. And trust matters, and you develop that over time. They didn't know who I was. I'm just a new person on the Hill and didn't know where my allegiances were and whatnot. But over time, we were able to develop that relationship. We were able to put down in our specs, if you will, what they wanted, what we wanted. We had the advocates come in, and together we worked on a bill. There are times when I thought I was a closeted Republican, quite frankly, because I said, why are we agreeing on this? It's too easy. Those were the days back then. Now I know it's a little more contentious, but what I have found also works where I'm at in Georgia. We have to work with a Republican state legislature, a Republican governor, and what we have found is that they don't like, unlike Democrats, the comprehensive sort of health reform, right? Or health policy agenda. They want more piecemeal approaches. And knowing that, we've been able to go in with that argument. We've been able to do our economic analysis, because economics and policy are two sides of the same coin. So when you talk about political determinants of health, I look at it in three buckets. How does it structure relationships? How does it distribute resources? How does it administer power? And then from there, we're looking at what arguments have resonated with Republicans, with Democrats over time in this movement to advance health equity. And what I have found from the research is that every single health equity focused policy in this country that has passed, especially at the federal level, passed because proponents of health equity were savvy enough to tie it to an economic or national security argument. And so that's sort of the same vein. In that same vein, that's what we've been employing at state levels, especially in the South, and it's worked in getting us resources to address maternal mortality, infant mortality rates in the South. We've been able to, convince the commercial interests that this is an issue that they need to take seriously because it does have implications as we become a more racially pluralistic society. So for me, in looking at my region of the country, it's fascinating the dearth of policies before, right, in terms of advancing health equity. But now we're becoming a lot more savvy, and we're able to see traction on this health equity movement in certain areas that were opposed to it before. But we have to be more savvy politically. So I totally agree with you on that. Public health is political, and we can't shy away from it. But we have to be savvy about what has worked and what hasn't.
So you brought up Georgia. So let's unpack that for a quick second.
Yeah.
So this was a relatively solid red state.
Yep.
And now they need multiple elections to pick their candidates.
Right.
Clearly, I think Warnock and Walker are going to a runoff. But then on the other side, Stacey Abrams underperformed her last election, and Brian Kemp won pretty easily. And when I was watching, so my secret is I watch Fox for my news because I like to hear what that side is saying. And so there was a gentleman in a bar in Atlanta asking people why they voted for Brian Kemp. They were celebrating the Brian Kemp victory. And it was a lot of COVID. It was a lot of, he kept the schools open. He opened the restaurants. He protected us. Now, of course, from my perspective, I'm like, no, he didn't protect you. He actually put you in danger. So here you are, a health equity leader, public health expert. How do you go about in a state like Georgia, which the ledge is totally red, governor's red, and so federal elections are a different bag. Right. That's a red state. Mm-hmm. How do you begin to develop a political path forward for public health? Do we just kind of decide to dig in and be idealistic and stand for ourselves, or do we figure out how to work incrementally? And I asked this also, I had the great pleasure of working on a workforce report with the state of North Carolina, and we had the report almost done, and it was a beautiful report. It was health equity centered, it was thoughtful, and someone on the committee said, if we go forward to the legislature with this report written as is, it is dead on arrival. But everybody in this room cares about health equity. Are we compromising our values to get political gain? Or do we stay idealistic and true to those values and risk not moving forward? That's an easy question.
Yeah, right? Oh my gosh. Well, politics is about compromise, but I don't think it's compromising your values. Because when I go into the state legislature, when I go into the governor's office, and we are pushing for policies that will help the most under-resourced communities in our state, I go in and we talk about, what is happening across the state. What is happening in districts where I don't even work, or we don't work as an institution? We don't have a footprint. And what we have done is to document. So we do scorecards, we do reports as well. We have our blueprint for action for Georgia. And we have worked with epidemiologists, we've worked with legal epidemiologists, social epidemiologists, and other public health scholars to help us look at what data sets we're able to get our hands on for these different counties. We usually create a map of the state. We highlight different chronic disease issues, and we're looking at where the governor, so I'm always looking at what the governor has put out as his top priorities. I'm looking at what our key members on the committees of jurisdiction over health policy have been advocating for, what actually matters to them. And we're highlighting that. So I'm not compromising values, but I'm trying to figure out how can we get them to actually push a bill that will help to address these inequities across our state, whether it's racial and ethnic, whether it's rural. How do I tie it so it matters to them? And for us, those have been quite effective when you show this is how, if you were to work on this policy, this is the state of affairs in your county, in your district. And we anticipate through our analysis that if you were to do this, this is the results you would see. These are the cost savings you would realize. These are the premature deaths that would be saved pretty much, right? And this is why this matters to the state of Georgia from whatever standpoint you stand on. So if it's the moral argument that works, we make sure to address that in the reports, right? For all my bleeding hearts, for those who really could care less about that argument, and I think majority of policymakers are really focused on dollars and cents, we tie that to the economic argument. It's a little bit more, it's a lot more effort, I would say, for us to have to do that, but that's what has resonated with our policymakers in Georgia in getting those piecemeal health equity provisions over the finish line and implemented.
So it sounds like, and Perry, I'll ask you, it sounds like political strategy should be something we're teaching in schools of public health, because I don't know that you can have successful activism without appropriate political strategy. Thoughts on that?
Yeah, so political strategy, yes, communication skills, more. And you know, I, like many of you, would turn on the news throughout the pandemic and watch experts talking down to me. And I felt like, if I feel that I'm being talked down to, what are the rest of the people in this country feeling, right? And so one of the strengths I think we do have in public health is being able to communicate in ways where we meet people where they are. Right? And if you haven't seen David France's documentary, How to Survive a Pandemic, which is his companion piece to How to Survive a Plague, which was about the AIDS epidemic, he did this, and it was released on, I think, HBO Max. And you know, he talks about the vaccination development over the course of the COVID-19 pandemic, but also talks about this neighborhood in Philadelphia and how boots on the ground and communication on boots on the ground change things. So you can do activism, you can teach activism, but only after you teach people how to communicate effectively. And that's what I think is really what we're doing really, really well at our school, I think, is like, how do you talk to people and meet people? Like, not everybody has a PhD, not everybody has an MD, right? Not everybody has a JD, right? People, the majority of people do not have those degrees. How do you talk to them in a way that makes them feel empowered, that they feel like they're making their own decisions, and they don't feel like they're being talked down to? And you know, you and I think agree on something, which is public health leaders were not on those news programs very often, you know, having those conversations, right? I'll say nothing else besides that.
Well,
and
we're going to say more. We're going to
the
say more.
communication would have been very different than what we saw.
So before we go on to our next topic is going to really look at communication and workforce, but I want to just ask the audience if they have any questions really focused on the election or politics, and those would be a good time now. So there are microphones in various places.
So I'm from a small university in Pittsburgh, Pennsylvania. I direct their public health undergraduate programs there. To me, when I look at the election results that came out of Pennsylvania, I don't see the red and blue divide, but what I saw was someone who had stroke, and everyone was asking questions about his ability to do the job. And most of the people came out and voted, you can have stroke as long as you're showing that you're recovering, it's okay. So in that regard, I think it was a public health victory. And moving forward, I have a couple of comments to make. One was the last point that you were talking about, that we need people who are not just, you know, in their ivory towers. And that means there is place for smaller universities who don't have kids who are capable of doing the top-level research because they can communicate. They are from the local communities themselves. And how can smaller universities work with, you know, the likes of you who are leading so that we can work together? So that's one question. And the other is, what is the public health lens through which we see the growing number of people who are, the acronym is NILF, not prime age men not in the labor force? Because there is a public health lens there. Why are people choosing not to work?
How do Cassandra Allen is from our team at Beaumont. We love Cassandra, she's brilliant. And we had this conversation recently over dinner about, when you go to some of those big schools, you leave with big debt. And it forces you out of a governmental public health path. And so here's my tip, my old man Yoda tip for any student in the room. The grades aren't important. What's important is coming to your first job with experience, with something to talk about. If the choice is getting a B in a class but doing a poster or writing a blog with a leader, choose the blog or the poster. Take the B. And more importantly, if someone asks you what your graduate school GPA was in an interview, just politely get up and leave. You don't want to work there. Okay? So just from a student standpoint, we don't all have to go to Harvard. Right? We can go to any number. That's authentic. I grew up here. There is a place, but I think there's more that small schools can do to reach out to folks to say, hey, come talk to my students. I never get to talk to students. I love it. 3 students in a room. Let's come and have a Pepsi and figure out how we get through this stuff. What would you, you were at ASPPH president. You were the capo di tutti capo of APHA, of ASPPH.
Chair-elect, but yeah, not yet. March.
There you go. So how are you going to fix it in March?
So one of my favorite books is written by Frank Bruni, who is a New York Times op-ed writer, and he wrote a book called Where You Go Is Not Who You Will Be, something like that. I may be sabotaging the title. And in that book, Frank makes the art, he first of all, he debunks the whole SAT thing and talks about the problem, the whole Felicity Huffman issue, that we all lived through. God bless Felicity. But what he really does really, really well, which I think is missed, not played up enough about the book, is this notion that if you're going to affect change in your home, in your community, in your state, you should go to your local school. Right? You don't have to go to the expensive schools, to the Ivy League schools, and go in debt. If you're going to stay here, that's the best way to do it. And what he talks about is the connections you make, the connections with politicians, the connections with the community. With regard to your question about research, and I say this with all due respect, as somebody who said, a lot of funding from the NIH. It's broken. That system is completely broken. And we have to think about how it is that we get money to institutions like yours and to community-based organizations. And by the way, the NIH finally released a call called Compass, which actually funds community-based research where the community is the lead and not the researcher in the institution. So slowly change is being made, but I would say, doing the work you're doing in your local community, doing the research. Sometimes the best research is little research as compared to the $30 million research or the $20 million research, and then reach out to places like our school, which are always looking to collaborate with local smaller universities to do the work within those communities. That's what I would say.
Also, I find so often that smaller communities, rural communities, talk about the deficits they have when they have amazing assets, right? People. You see, you don't necessarily see the New York City Council person shopping in the grocery store and just say, hey, how you doing? But you went to school with the councilman and their mayor. There are long-term relationships. And Karen DeSalvo, when I got to work with her, and Karen's brilliant, she said, there's a lot you can do with a nickel and some friends. Right, and I think we lose. It's those relationships are often harder in cities, large cities, right? Because there's so many different aspects to it than rural America. And so we got to think asset-based, right? You have an amazing small school. You have amazing people in your undergraduate program. Have that asset base. I think it's interesting that public health always models the disease, and we never model the resilience.
Right, what people are doing right. And you're doing so many things that are right. And I would say that one more thing, one more story, which is I went from NYU, where I was for 20 years or 19 years, to Rutgers. And it was a drastic change. And at NYU I could do whatever I want. There was money flowing everywhere, blah, blah, blah. It was lovely, right? I have to be scrappy now. And you know what? The work's better as a result of that.
Another question. Oh,
Can I
go ahead.
actually
Yeah,
just add
please.
something? So I'm really glad you raised that question, because there's a tension going on right now within CDC, within the NIH, CMS, around community engagement. And I'm so glad you addressed the issue of elitist views on what kind of research should qualify for funding. We need help to keep pushing HHS as a whole to prioritize community engagement and to not on this hierarchy of whatever research, not put it at the bottom. So I think that's one. We need as much help as we can, because we see the discrimination. I see it across all agencies when it comes to this. Even the Office of Minority Health, and I will call them out because I love that office. We have fought for years to get this office stabilized and to sustain it moving forward at HHS. But again, you have folks who don't recognize how important that element is. So I would absolutely say that is critical. The other piece that I would encourage folks in the audience to help us with, there is a debate that has been going on, and Monica Lopez-Valdez and I have been co-chairing the Health Equity Working Group at CDC, and it comes down to funding as well. So we have community-based organizations that are saying we'd like to do more beyond the REACH program at CDC. We would love to get involved. We believe that the people who are closest to the pain and the problems in our society should be leading those solutions. And yet it is amazing to me when you look at the flow of funds, how very little rather goes to entities like yours that actually have strong ties to the communities and have been anchor institutions in these communities. So we need help to push CDC to really address that intersection of funding as well and community-based organizations, so they can do that kind of health equity work we need in the communities. So just two things to think about moving forward, and I think that might help us too.
Marissa.
I think this is a great conversation. The leadership approach we're trying to take rests on a couple of really critical principles and a real mindset change. Much of what we've done and what we think about is very mechanical and machine-oriented, but we're living beings, and our communities are living entities, and I think public health is in the right place now to really take a living perspective, a life perspective, if you will, and to understand what the conditions are that promote thriving for all life, and certainly for all human beings. To that end, I'm always amazed at how we approach communities with a lack of respect, first of all, from a deficit perspective. And back in the 90s, I learned about asset-based community development and have been trying to push this, but so much of our institutional approach, our culture in public health is about deficits, it's about disease, it's about problems. And when we try to engage, we miss the boat because we don't connect through respect. And you can only do that if you value each other as equals. And I'm not an indigenous person, but I have come to realize it's not new thinking we need, it's to appreciate the old thinking from our indigenous colleagues who already learned how to live harmoniously, not only with themselves and each other, but with their ecosystems. And I love the simple advice when you're approaching others, you have to start from a place of respect. And I think that's very consistent with an asset orientation. It's only then that you can really connect, because we're equals. But that connection then allows you to reflect. It requires you to reflect to really understand who it is that you're trying to connect with. What is their life course? What's different about them? What do they have to offer that you maybe didn't appreciate? And then it's only after that that you can direct something. And we've had it all backwards. We've gone in and directed. So community engagement has been, we're coming to help, and we talk about this all the time, but we still do it. And we come at it from a deficit perspective. We have an incredible opportunity now, I think COVID and everything else that's happened, to come at this from a living systems perspective where we come from a place of respect, we connect with people, and then we have an opportunity to reflect with each other so that we can work together and create that shared vision that allows us to take those political steps, not because we can get it done and compromise, but because they're the right step to get us to the shared vision of where we're going to go. I think this is the process that we can follow, and this is what we're calling a regenerative leadership approach, because we really need to regenerate ourselves, each other, our ecosystems. And we have an amazing opportunity now. I'm really optimistic about it because I know it's coming. I just hope that we don't have a lot of damage in the meantime.
All right, next question.
Yeah, good morning. Great presentation. So my question is, well, comment. So earlier you said that public health is political, and I don't disagree with that. Some of the recommendations that we make to our elected officials, do we need to consider the economic impact of those decisions as well? Or do we sit there and say, hey, you know what? No, COVID's a bad thing. Lock everything down. The economy be damned. This is the right thing to do. Or do we need to consider the economic impact of those decisions?
We absolutely have to consider the economic impact of those decisions. If we are speaking in isolation, if we're not considering that, hey, everybody, let's face it, we closed businesses. Some of them never opened again. We did that. So we, as a public health community, often say, this person caused harm, this person caused harm. Let's be clear, we caused harm.
Yep.
We did it for the right reason, but we caused harm. And if we ignore that, that's when that annoyance starts to build in the belly. Marissa, what do you think?
So I would love us to really take a well-being perspective, because when you start thinking about well-being now, it's not just physical health or physical well-being, not just emotional well-being, which is critical, but now it's social, financial, and spiritual, the whole thing. And I think that's what we missed in COVID. We missed the fact that people want to be well. They define what wellness is, or well-being, but we have to work with them, and we have to make sure that our collaborations include people who have those different perspectives so we make better decisions. Quite frankly, when China locked down Wuhan, that became a standard, and we just incorporated that. We really didn't stop to think about what that meant for well-being. But if public health could embrace well-being, and if we could have, this is an emerging science, I think it's a real opportunity, and a lot of good has been written about it. If we have the opportunity to look at well-being now and appreciate it, I think it allows us to connect with people in a way that's much more meaningful. And it's not ever going to push the politics aside, but maybe we can rise above or skirt behind the politics to some degree.
Can I add something to what Marissa just said, which is, like, nobody wants to get COVID, no one wants to get HIV, nobody wants to have a meth addiction, nobody wants to have an opioid addiction, nobody wants to be obese, nobody wants to be, like, addicted to cigarettes, nobody wants these things. Right? You don't wake up one morning and say, oh, I know, I think it's a really good idea, I'm going to be a meth addict. That's a really good idea. That's not what happens in life, right? And these things, we use these paradigms in public health, tapping to what you said, that completely focus on just behavior. Mm-hmm. Not emotional lives, not social lives, not financial lives. Just to this gentleman's point, it is critically important that we think about the economic circumstances of people when we make these public health decisions. It is incredibly important for the medical profession to realize that the woman that they're prescribing HIV meds to has 3 jobs and 4 children and may not be taking their HIV meds every single day. And said, unless we do this holistic understanding of well-being, which is bio, psychosocial, and keep adding things to it, we're going to keep missing people. People will continue to develop illnesses, and people will continue to die. And I don't know how else to understand. Maybe it's because I come from a psychological perspective, in my work. That's what was my first discipline, and thinking about the interpersonal in people's lives seems to be the thing that has to be at the center. This population thing, right, that we're doing in public health, that we think about the population is really good, but the sweet spot for us is in the middle between the person and the population, and that's where public health needs to go.
We're going to take another question now and then back to some of the questions we had pre-planned. So please, question.
My question has to do with communication. One of you guys spoke about communication. So as public health technicians or experts, are you okay with the way COVID is being communicated to the public?
No. No, but let's talk about that. Okay, this is the audience interaction portion, okay? What did Trump want to do to Hillary?
Lock her up.
Okay. What did he want to do on the southern border?
Lock.
What's Nike's slogan?
Just do it.
You love words.
I do.
You are always trying to think in social spaces, you were more kind of, computer native than I think any of us on the panel. I learned Word and WordPerfect as a sophomore in college. Remember WordPerfect?
Yeah.
What do you mean? I had to type it.
And when you think of 3 words, because usually you have this great stuff, build that wall. We don't like those messages, but we remember them.
Right.
And then someone says, well, what's public health? And like 4 days later, that's public health. And then you notice like everybody left the room. What are the 3 words, Zamir?
The most common words I hear is public health is everything.
But if you're everything, aren't you nothing?
Yeah.
That's what I'm trying to figure out. It's come up on, a few conversations recently, and it's like, so what does that actually mean? It sounds good to us in the room, and it's like, okay, we're empowered, but then where's the action? When you're talking to the community, when you're talking to individuals, and it's like, oh, I do everything. Okay, but what do you do? I put a poll out on LinkedIn recently. It's like, how do we even refer to ourselves? And, a lot of people said public health professional. And again, as you said, I like words. And I said, okay, so I should be able to look this up in dictionary.com, Merriam-Webster. There's no public health professional in the dictionary, but you can look up doctor, you can look up lawyer. So what do we mean to everybody else? How are we communicating that? We don't have the words, we don't have the vernacular, we don't have the vocabulary built out on how we actually communicate with the general public. Because what is a public health professional? A lot of us might consider ourselves public health professionals in this room, but we're not doing the same things. When I talk to my family that are lawyers or doctors or anything like that, they don't say I'm a medical professional. They don't say I'm a legal professional. Okay, I'm a cardiologist. I'm a public interest lawyer. What are we in public health? What is a public health professional? And to summarize, I don't know what the 3 words are to just easily describe public health. And it's something that it bugs me.
We are working on these 3 words at Beaumont right now. Follow Beaumont. We're working to get an evidence-based 3 words. But Daniel, give me 3 words.
I knew you were going to say that too. And I was thinking about this and struggling. I'm the one, when I go on a radio show, especially to our colleague's point about conservative radio, I fluster people because I don't see things in these sound bites, and it is a complex issue. So I guess my 3 words might be, or maybe I could put it down to 2.
That's even better.
Lives. Maybe saving lives.
Audience, 3 words. Just shout them out.
Protect.
Well-being.
We do well-being, yeah.
Prevent illness. Health for all.
Oh, I like that.
That's good.
Yeah.
Quality of life. All right, so this is the stuff that, again, after we're done, again, please let APHA not be a first date, right? APHA isn't the first date, and then you're like, I'll wait a year for the second date. Okay, we have a lot of dates in between this APHA and Atlanta. This is the engagement we need to keep having. And we need to hear 3 words from us, but we need to hear 3 words from people who don't like public health. Right? What's that messaging that they have?
Let me just say, as somebody who spent a long time planning for COVID, and I left service before COVID, I realized, particularly early in the pandemic, that we did a horrible job of educating people about what a pandemic was. So many people said 3-4 weeks, lockdown, everything will be back to normal. I heard this all the time. And I think one of the critical aspects of communication is what we do before an event, before an issue. But you can't, remember, communication occurs through relationships. So again, it's back to having those relationships, those trusting relationships. And then we have to figure out how do we talk about things that people don't want to hear about. So at least they're aware, but not so much that they have to know all the detail, just that they'll trust us so that when we do get up in front of them in the emergency, they'll actually listen. They'll actually listen and believe. And I think that front work before the event is absolutely critical. So communication matters.
You got the political side of your job. You understood it, right? And you said it here, just not the politics, but that you were campaigning for public health every day.
Every day.
Right? So
yeah.
you met with people. I mean,
You had to.
Again, we all love public health on this stage. We all love it in the audience. We're not going to be apologists. When we knew that there was a respiratory virus circulating throughout the U.S., we did not, far too few public health leaders brought their business communities together and said, hey kids, buckle up, buttercup. Things are about to get rough. Here's the best case scenario, here's the worst case scenario. When we engaged them was when we went to shut them down.
Yeah.
That's a bad first date. No one's swiping right on public health from the business community right now. And they shouldn't, honestly. So I hear far too many health commissioners saying now, like, whew, I don't have to do those Facebook Lives anymore. Isn't this the time we have to do them?
Exactly.
This is, remember, this is an interpandemic period now. This is where, well, maybe it's not interpandemic yet, right? Hopefully we'll be there. But this is the time where that activity, those trusted relationships have to be built. And in many cases, they have to be rebuilt, which means a lot harder work, unfortunately, because we've lost them. And one thing I'll mention is this regenerative leadership approach we took. The first thing I did was partner with the business college at my university because I knew as a commissioner that I always wanted to have better relationships with the business community, and at the community level, if we got the employers to do a lot of the public health stuff, then that trickled down through, this is a trickle down that's good, trickled down through the community and affected many, many more in the community. And they had resources to do a lot of the public health work as long as they appreciated they actually had a role. So this is absolutely the time to create those relationships. And again, I'll go back to at the local health department level, that's the opportunity.
Barry.
So I would say two things, sort of just to add to the conversation. Number one, history. So for those of us who are old enough to remember, like myself, when HIV first appeared in 1981, there were 5 years of uncertainty about what was going on. There was not like this, we knew this virus was happening. I didn't know, I was a young gay man in New York City. Should I touch the doorknob? Like the doorknob, the toilet seat became like the supermarket bags of COVID, right? It's the same thing. I was like, again? We're like having these anxieties. So I think one of the things that public health can do better in preparing our students for sure is teaching them this historical context and recognizing that, that we've made great strides. Now, having said that, one of the things that I think we've misstepped at is in the communication is not acknowledging that we don't know. We are so stuck in this, we have the answers for every single thing, that when good leaders, I think, of schools of public health say they don't know. Good leaders who are politicians say they don't know. And that's how you build the trust between people. And I think the words are people at center, or people at the center. It should be the thing we think about public health, because that's where we often fall short when we forget that the people are what we're there for ultimately.
Question from over here.
Yes. The word that keeps coming across my mind as you're talking is timing. Mm-hmm. And I'd love to hear your thoughts on timing and presenting messages. And I mean, communication is as much about timing and relationships in my mind. So I'd love to hear your thoughts.
Well, let's also weave in data modernization of that question as well, right? Because the 2000 or the 2022 fentanyl report is data from 2 years ago.
Yep.
So our timing's always a couple years behind when we really look at our data. Who wants to talk about timing? Okay, there you go, Marissa, take it away.
Yeah, first thing I'll say is absolutely. So the question is, can you be ready when the time is right? And that's a very important point. I remember in my commissioner role, we would look at the calendar year and say, what do we know is likely to happen? Well, we always know that we're going to have a flu season, so what's our plan? What are we going to do? And when we got to the point where we started to have some predictive capability, like neurovirus, we were now with surveillance, we could say, here's a baseline, we're above baseline, we know in a couple of weeks we're going to have maybe a significant outbreak. We're prepared to deal with that. All preparedness is about having things ready to go when the event happens, realizing you can't know everything, but the question is, what can you be prepared for? What can you be prepared to do? And at least can you have a template that you can fill in the details? So I think anticipation is really critical. Having a preparedness mindset is important. And then being aware of the fact that there are cycles, and in those cycles, There are things that we can, to some degree, predict, like a flu season, for example.
I think a really important aspect about preparedness is not necessarily us. Well, yes, we should be prepared as public health leaders, but the community should be prepared, and the people who are affected should be prepared. And here's my case in point. Who's like sitting around in May when this monkeypox thing is evolving in Portugal and thinking, oh, it's not going to come to the United States? Anybody who knows how people socialize knows that there's some gay man from the United States at that rave.
Right.
Not me, but others, right? How is the federal government is just like watching this, right? And not necessarily acting. And we have this horrific outbreak. But you know where the communication happened and the timing happened effectively? In the community. And what you saw was a response. Now, obviously, there's still problems, but what you saw was a curtailing of this outbreak because people recognize the importance of vaccine, but they also recognize that they had to talk to each other and take care of each other, right? And to change behaviors. And that is an empowerment. That's an ACT UP thing, right? That's an empowerment that's just ground up. And when that happens, it's incredibly powerful.
We have an ACT UP.
Loss of faith, because when you hear that it's not important, but the communities
Yep.
talk about it like it is important, and they're suffering, but trust is broken.
That's right.
Yeah.
All right, next question, then we're going to talk about ACT UP in a second, but next question.
My 3 words or 4 words, we the people, a more perfect union. Eyes on July 4, 2026, the 250th anniversary of 1776, if everybody knows those words. And then halfway between now and Atlanta, the first Monday of March, the Beaumont Legislature, Massachusetts, we will have first annual COVID Remembrance Day. We'll take the symbol of the National Center for Bioethics at Tuskegee, the Sankofa bird, looking backward in order to move forward to what we want.
Right.
And engage everyone who's been affected by COVID, which is everybody, to look back individually, personally, connecting the personal to the macro, to reflect on that, maybe grieve, maybe atone, whatever, and then say, in this inter-pandemic period, what am I going to do so that my future loved ones or myself next time do not have what I'm grieving today? And if we can work concretely with Daniel, whatever, I'd love to talk.
That's great. I mean, everyone has lost in COVID. Maybe not their life, but we've all lost something. It should be a national sharing of loss and grief, and I love that idea. Okay, Perry, we're going to talk about something controversial.
Uh-oh.
All right, so let's buckle up here. I want to be very clear that threats of violence are simply unacceptable. And it forced our colleague, Dr. Wen, to choose not to come to this APHA. I vehemently disagree with Lena on much of what she says, but threats of violence are unacceptable. However, many of us have been in government positions. The bullying, I think we think is new. I'm not sure that it's new. Years ago, when I was over fluoride, I had anti-fluoride activists in my office, and there was not violence, but it was definitely activism, and it was aggressive.
Pleasant.
Think about the HIV/AIDS days, the ACT UP days, right? These weren't like polite conversation had over tea and crumpets.
No.
Would we view what ACT UP did today as bullying?
No.
And what's the difference?
No, because we were angry, but we weren't cruel, and we didn't dismiss people. We disagreed with Tony Fauci a lot on what he had to say, but what we wanted was from him to be at the table, right? And I think that was the difference. Nowadays, we just want to erase people, right? And it is the erasing it is the bullying that doesn't lead to, like, Nina should be here, right? Like, I don't agree with her either, right, on most of the things that she says. But she should be at the table having a conversation with the rest of us. We don't all have to agree, but her perspective matters as much as the rest of our perspectives here. And that's what we did with ACT UP. We said, again, it comes back to this people at the center. We never were cruel. Like, I guess we yelled at Tony a lot, God bless him. So he was like used to us. But ultimately, we just wanted to be heard. And we did it through 2 things. 1, data, knowledge, information. Like, how can you fight us on this? And 2, through raising up empathy and showing the losses that we were experiencing. And I think that those 2 things are the things that ACT UP did. The information and the empathy coupled with the theatrics, which I think is sometimes some of the best theater that ever happened in New York, was ACT UP in the 1980s, and that was effective. That's not what's happening now. Right now, we're
But you
beating people
closed
up.
my business. You're not listening to me. You closed my business. And for, I think for gay men, for others in the 80s, this was a life or death issue. And now I don't feel that you're listening. I didn't feel that you listened. I didn't feel that any of you listened. I didn't feel you listened to me, and I'm losing my business. And so how is, like, where did we cross the line between activism and bullying? Because just because we agreed that we should have more research, so we philosophically agreed on the AIDS topic, but we don't philosophically necessarily agree with the anti-COVID crowd. So
Right.
how do you make the space to even have the conversation?
Because we didn't bring those people to the table at all in making the decisions, like in many jurisdictions. We didn't ask the restaurant owners in New York City what they thought about this. We didn't bring them to the table to think about how they can keep their businesses open and deliver food and stuff. They had to figure it out on their own, right? And so that was the difference, I think, between then and now.
That I want to punctuate that for everybody in the audience. We have to own, as public health professionals, that we dictated, and we didn't. We're the poster children for inclusion, and we didn't include the people who were going to be affected by the decisions that we made. No one called me and asked me, can we have a community meeting about my school? Like, hey guys, what is this going to mean when we close schools? You know what it meant for me as a relatively well-off white guy? It meant my kids were in their rooms. It was great. I still worked. My wife still worked. It had very little impact on me. There are friends that my kids had who we've never seen again. They're lost children of COVID. But we never reached out to that community. We didn't live our values. We didn't live our inclusivity value, because it shouldn't just be inclusive for those who believe in what you say, right? Inclusivity means everyone. And probably most importantly, those who disagree with you. Marissa.
So this is really about authority and mandates, and we have to be very careful. I remember as commissioner, to me, the mandate was the last step, and it was the last step in a series of actions, sometimes taken very quickly, but a series of actions which gets to what you're just saying, that you have to have inclusive decision-making process. And I always felt that if I had to mandate that I failed in some way, shape, or form, because I knew I was going to potentially lose the authority if I implemented a mandate. And I remember, quite frankly, with Ebola, we had over 2,200 individuals coming from the West African countries through Dulles that we had to evaluate and quarantine. And I'm happy to say that the folks that I worked with, we were able to do all voluntary quarantines, no involuntary quarantine, because that would have been, again, the last step. We did everything we could to prevent that from happening. Now, COVID, we had a shortened time, but we didn't really do those steps. We just jumped, and we abused our authority to some degree. And I don't mean that that maybe it was the wrong thing to do, but it's the process that we have to follow. And I think we have to be really careful about our authority. And quite frankly now, especially with results of the elections, we may continue to see a lot of our authorities lost. And unfortunately, I hope we never need them, because it'll be really hard to get them back. So mandates are really difficult, and we have to be humble about how we use them.
Because viral outbreaks and pandemics are not just biological events, right? And that's what we did. We treated it as a biological event, not how it affects the kids at school. My husband's a special ed teacher in New York City. Those kids are lost, like lost. Businesses all around my neighborhood in New York City are closed, right? We forgot all the other parts because it was just about the virus. And this is where public health got it completely wrong.
I want to talk about something that is a growing theme in public health, and it's community engagement. We are really good, and so it's coming to you because I'm looking at you.
I see you.
We are really good at saying words.
Yeah.
We do health equity. We need more community engagement. I watched a whole panel once on community engagement, and the first conversation was, how do we engage the community more in public health practice, in governmental public health practice? And the next conversation was, how do we get more people with master's degrees to come work at health departments? Those seem to not necessarily be, aligned. I think we have a pendulum that's swinging, and we need academically trained people. So it's like, that's the chocolate, if you will. Then it swung all the way over. It's like, no, we need people with lived experience only. That's how we're going to do this. And that's the peanut butter. And while peanut butter and chocolate individually are really good, if you put them together, you get a Reese's.
Right.
How do we make a path forward where we are hiring people from the community into paid governmental public health positions? What does it mean to operationalize community engagement and not just say it or have some 3 o'clock meeting with no childcare and say, oh, look, hey, community, thanks for coming and giving us input on our strategic plan. What does community engagement mean?
So you know, we've written a whole book on it, and I know we don't have that much time, but for us, again, it is recognizing.
What was that book?
It's called the Morehouse Model.
I didn't know that book.
Community engagement, yes.
Plug the book.
Hopkins University Press published it.
Thank you.
And colleagues of mine at the Department of Community Health and Preventive Medicine worked on that. And so for us, you know, we have long established ties to the African American community, to Latinx community, to the unrecognized tribe in South Georgia. And what we have done is, again, that economics argument, when we have pushed for, let's say, workforce development, and it's around public health workforce, we've worked with our policymakers to think about, for instance, can we find a funding mechanism through Medicaid that would fund community health workers in the state? What can we do to get them through that pipeline? So we have a host of pipelines that are in these communities, especially communities of color that have some of the lowest employment rates in the state. And we have these pipelines. So if you're interested in public health, you're able to go through these pipelines. If you're interested, if you want to send your son or daughter, you know, to learn medicine, we have these STEM programs that we've worked on with the community. And again, we look at it through the entire life continuum. So depending on where you are, we have programs that we've established for folks. So let's say you are an adult and you want to get engaged in public health work. We developed a political determinants of health learning laboratory where we bring individuals. It doesn't matter your educational status. You may have a first grade education. You may have a middle school or high school. You may have college if you're fortunate. And what we've done is we bring them through this year-long program. We connect them with a policymaker in their state. We connect them, we mentor them, we help them build out their networks with folks who have influence in business. We talk about the commercial determinants of health, we're talking about political, we're talking about social determinants of health. By the time they are done, they come through as feeling more empowered. They're stronger advocates for their communities. And then we try to connect them then to the funding opportunities. So if you don't want to work in government per se, you don't want to work with our Georgia Department of Health or our Fulton County Department of Health or which other county of health, then if you have that entrepreneurial spirit, we're connecting you with the foundations, the Healthcare Georgia Foundation or another foundation, that you can get a grant and continue the great work that you have been doing after you leave our program. So those are the ways that we've been engaging folks. If you look at the work we've done with grocery stores and trying to get these different entities to provide more healthy food options, it's been fascinating how we've convened these community advisory boards to help talk about what are your experiences relative to that issue, right? Or it could be food security. Once we've done that, we've identified these things, we then work with the business interests in that community to rectify it. We talk about business opportunities for them, perhaps within those businesses, but that's how we've been engaging throughout the years on that issue.
Brian?
Yeah.
I love that work. I think the networking, the pipelines are really critical. I wanted to talk about something foundational, I think, around the mindset that we bring into this work. Because I think there are two really important aspects. One is a positive approach as opposed, again, to only focusing on the problems. And the other is an asset orientation, which we've talked about. So I remember when I became commissioner, we had always produced an infant mortality report. And I kind of stepped back and I said, what is it we're promoting here? Dying infants, dead infants? Why don't we really rethink this? Because this is a public-facing document. Could we have something like a thriving infants report? And could we maybe flip the data so we're talking more about survival? And I went out to the local March of Dimes and other entities and engaged parents and realized that this positive approach was incredibly engaging. I mean, they were happy to deal with the issues, but there was something about the positive energy that made people want to connect and be involved. And I continue to see this approach. So now I teach it in the leadership approach that we really have to think about positive approaches. It doesn't avoid the discussion about the negative, but it helps us really get to the engagement and the aspiration. And then the other more simple thing is that everybody working in public health already has assets and connections to community. And if you have the mindset that maybe let's just stop and take inventory of who is connected where, that the tentacles into community might become more obvious and make some of those programs and connections that you're working toward even easier. So just keep that in mind, and I think this really is foundational in terms of our mindset.
Samir, what would you share?
There's a few things that are going through my mind right now. One thing is, building off of what you're saying, is that we're only looking at this as the problem. We want to engage with the community when there's a problem, instead of saying, okay, how can we engage with the community before there's a problem and actually start building relationships? Until a question earlier about the timing. We need to always be building relationships all the time. You know, it doesn't need to be just when we need someone. This goes even to networking. You know, I see a lot of people that want to start to network when they're looking for a job because they're like, oh, you work there? I want to tap in with you now. You should have been building relationships with that organization before they had that job present, but we can talk about that later. But we need to start building relationships continuously all the time. The other thing is, I'm thinking about how community engagement is taught at school. You know, when we're taught in community engagement in a bubble. I opted to take my MPH online because I got tired of being in the brick and mortar space. We talk about community engagement, we're doing community engagement with other undergrads, other grad students. You know, it's very seldom that you actually go into the community that you're talking about. And it's difficult. You know, I was in Durham, North Carolina, trying to find opportunities to actually participate in our local health department, to go to nonprofits, you know, and actually engage in the community. And sometimes you couldn't even do that because they said, oh, well, you're not doing it through UNC Chapel Hill. And I was at GW remotely. And they were like, oh, yeah, we can't let you in because you're not a part of this particular program. And so how does that allow me to actually learn how to do community engagement? How do any of us learn how to do community engagement in a classroom? You can't possibly do it.
I would also say, I'm going to twist it to education for a second, because while Brian thinks I'm an activist, I'm also an educator, because while I was an activist, I was also a 6th grade teacher. Did you know that?
I didn't know that.
Where Lin-Manuel Miranda was in my class, so talk to me about that later. I mean, he's still my bud. But education, so here's what, when I first got to Rutgers, I thought, like, wow, like, what is this school doing to prepare the public health workforce besides bringing in MPH students? What is it doing to serve the departments of health? And when we look at the Newark Department of Health, half of the people at the Newark Department of Health don't have any public health training. So that's not cool. And why is the leading school of public health in the state of New Jersey not doing anything about that? So what we did is we created a near zero cost opportunity for people in the Department of Health to come in and get their degrees, their certificate first, and eventually their MPH. And we just got money from HRSA to fund that too, which is like incredible. So community engagement is not just about the research. The educational piece is there. And I feel that in the community engagement research piece will happen much more readily when people working in departments of health look like and reflect the populations that we are serving. And right now, that's not the case. And so we have an obligation as schools of public health to prepare a next generation of scholars who are activists and who are smart and who know biostats, which is what I love to teach, but also who are representative of the people that they are going to be working with. Otherwise, we are again having this very exclusive club that is not speaking to the majority of the people in our country.
Next question.
Thank you. Actually, this question is for you. You talked about our failure to communicate, to include all sectors of the community when there was a pandemic and there was that urgency. So I want to ask you, and this again is community engagement, how you operationalize an involvement of community when you are in the throes of a disaster. Well, wait a minute, let me finish, because you're talking about the schools, you're talking about the businesses, you're talking about various sectors within a community, and the community lines aren't clear to me. Are you talking about a town, a county, a region, say within New York State, or are you talking about the whole state? Who should actually convene this, and how do you operationalize inclusion from a public health standpoint?
You operationalize inclusion before the disaster starts. These had to be relationships that we had, that we developed.
No, but where are they?
What do you?
So what I'm saying is,
your governmental public health department, your health commissioner, your CBOs, we need to have an ongoing conversation. This is not us in our, public health. Health is a team sport. We had to bring the team together before this happened, so then when there was a crisis, when you were down 10 points in the fourth quarter, you already knew how to talk to each other. You already knew how to make these changes. And what we saw, and another good resource is the Health Action Alliance. You can find that at healthaction.org. We translated CDC jargon for businesses who kept looking at the CDC guidance, wanting to do stuff, but not understanding what was said. We have a bivalent booster. Who named that?
Yeah.
So this is something we have to be the quarterback for our community when it comes to health. It goes back to the chief health strategist model. And yes, in the town, in the city, in the region, in the state. But our patient, we didn't talk to our patient, if you will, which is the town and the region and the community. We didn't talk to our patient before we practiced on them, before we actually imposed the treatment. And that's where we have to own that. I mean, listen, I think we've had a really hard time, but I don't think that we're going to really get better just reflecting on how hard it was. We have to own some of what we did.
Let me comment. After 9/11 and anthrax, we really became part of the public safety community, which I think was a very good thing. We created relationships, we learned the jargon, we learned the processes, and I'm a big believer that we have community systems that we ought to work through. So at the local, at the state, at the national level, the issue, I think, is that the locality, the local system, the local response system really needs to be in charge. And the state and the federal government need to be supportive. And we saw in many states that the localities were snuffed in terms of their activities and processes. But that system is there. I think we have an opportunity to make that more robust, to be intentional about how we get community input before the event and even during the event, particularly for a prolonged event. So I wouldn't want to throw out any of that. I want us to have a better appreciation for the fact that these systems are in place. I just saw in the hurricane arena that the system was being utilized, but again, there's no shortage of volunteers. People want to come in, but they don't always work through that system, and then they're less effective, and they actually can cause some trouble. We have a great opportunity to build on that foundation, but I think it has to bring in the health equity concepts. It has to be more intentional about how we have those conversations, how we get feedback, how we give information, and I think it would really help. But I really believe at the end of the day, the community, town, county, whatever you want to define, is the critical say-so, and we should be in full support of that activity.
I hope in Atlanta we can support a great debate series in public health to have these conversations that help steel us for the future, that steel can sharpen steel, and we have these conversations. I have to take the last question because, believe it or not, 90 minutes goes very fast.
Wow.
Yeah, I had the clock here, and it's like stalking me. Great question from online that I want us all to answer. We've talked about a lot of stuff, okay? Community engagement, politics. So the last question from our online audience, and online audience, thank you for staying with us. Talked about a lot of stuff. What are the pathways to train a workforce that can do all the things that we're asking public health to do? I mean, in a lot of ways, Public health is like a Golden Corral buffet. We do a lot of things, but we have to do it good. Sorry for the shade, Golden Corral. How do we do all of this? How do we achieve the health we need? And how do we change our schools and our training so that we can do it right? Perry, you're going to start.
We're going to start by ensuring that everybody, including the youngest children in our society, understand what public health is, which is bringing public health to the classroom, not at the master's level, but at the second grade level, so that they understand it. And if they understand it there, then and that's number one. And number two, we're going to go out into the world and recruit people who are dedicated to the well-being of their communities, and we're going to provide them an education that's relatively inexpensive and ask them to serve their community after that.
Before I'm done, I'm going to write a children's book for like 3rd, 4th, 5th graders on public health. It's my one thing I want to do so badly.
Exactly.
Because I think my 11-year-old daughter, I think she could pass Epi 100 just knowing fractions. I think I could get her through it.
We do every summer in Newark and New Brunswick a 1-week public health summer camp, for lack of a better term, for high school students. They come into that, they don't know the difference between medicine and dentistry and public health or any of those things, right? So that 1 week is another way of recruiting people into the pipeline for something that they've never even thought about.
I want to be a camp counselor.
Okay, good.
Marissa, what do you think?
So I want to build on that because I think that I'm a big believer that if we want better and different outcomes, then we have to create a new model. And the new model of public health should be a distributed model. Getting to your point, everybody has a role, and it's got to be networked and aligned. And the best teacher for this is nature. Nature's already learned how to do sustainability. So if we just listened and learned from nature about how living systems actually work, we would realize that networking is critical, and we talked about connections and relationships. They need to be robust, they need to be adaptable, flexible, and if we can create a public health system like that with leaders at all levels in different sectors and have community capacity to connect and let our technology support that, I think we're in a good place.
Zamir.
I'm really focused on support. Like, how do we support that public health workforce? Of course, how do we train them? But how do we support them? What are the resources that we provide that workforce? What is the incentive to actually work in public health? You know, definitely going to what is public health, you know, getting that started early, you know, but getting it in front of people, you know, as well, how we're communicating that, you know, and as well as, okay, if you do want to go into public health, are you actually going to be taken care of? Like, is this something that you're going to be able to do that will actually not destroy your health in the process? Will you actually be able to live a, well, I mean, I think a lot of us are frustrated, but a rather happy life in existence, you know, and not be stressed and burned out every single day of your career?
Daniel.
And to piggyback on what Zamir had actually initially stated, right, with the identity issues we deal with in public health versus, let's say, law or medicine or whatnot, I think we need to expose children who aren't on the upside of privilege and advantage. Give them that exposure early on, to your point, Percy, about you know, getting to them earlier on. I think that's absolutely critical. I know there's a CDC summer camp, and yet I think a lot of children of color have never had an opportunity to get involved in that. I think that is an area that we could see tremendous advancement in. I think there is this movement in academic medicine around you know, lowering the debt burden for students. I would love to see public health education more accessible for students, and I'd love to see programs where it's fully paid for our students. So when they come out, they're not burdened by that debt load. They're more courageous, right, in their push. And then lastly, strengthening advocacy within our public health programs. I think it's so critical that our students, to your point, Percy, when you talked about communications, yes, that's key. I do think that in order to be very savvy and successful moving forward, they need to understand what it's going to take to be effective advocates. So those would be the pathways.
Sorry.
Yeah.
Yeah, and I think we need to look differently at how we view communications. You know, I don't think it's always just another program. I think I never heard about the CDC program.
Right, exactly.
That would have been great. But also, how do we get this in popular media? You know, I think a lot of times, you know, we think about reports, you know, we think about, okay, like, how can I just, like, get this in front of people? But, I mean, when I wanted to be a lawyer or a doctor or something like that, it's not because I just read some article. It's because I saw it on television. It's because I see this represented in the media. So how do we also make sure that we're relevant in popular culture? How do we make sure that it's in front of people? Because we need it in the classrooms. We need the second graders to know about it, but we need the masses to also see it, represented appropriately, in the day-to-day popular culture.
I will add loan repayments so my friend Heather Krasna will not troll me on Twitter. Thank you, everybody. I want to first thank Dr. James Sprague. He's our board chair. He's here. I want to thank Pete de Beaumont for giving me the absolute joy of my life to lead this wonderful foundation. And remember, just like Arby's has the meats, the Beaumont Foundation has the tools for public health professionals. Follow us, engage with us. We will see you all in Atlanta. This brings the de Beaumont Group to a close today. Thanks, everybody.